FHM team. We're really looking forward to today, and we'll probably get started in just a couple of minutes, give a couple more minutes for people to join, and then Farhan will kick us off.
Yeah, great, thank you.
And always good to see familiar names and new folks as well. So welcome. All right, what do you think, Farhan? Shall we go ahead and get started?
Yes, Andrea, I think we can start. So once again, thank you everyone for joining us for this month's session of the Healthy Markets Community of Practice. As we all know from the emails, this session will be focusing on Liberia as a country, as we have been doing over the last few months. And we have some very interesting and exciting presentations, as always, from Liberia to go through today. First, Andrea, do you have a few opening remarks before we jump in?
Yeah, thanks, Farhan. So again, welcome to everyone, and a thanks to the FHM Engage team who serves as the secretariat for this endeavor. And for those of you who might be new, just kind of a reminder that this is sort of the refreshed approach from what we used to call the total market approach technical working group. And this healthy markets community practice is very much focused on family planning and market development. We also want to call out that we have invited another technical working group to join us, and that is the Pharmacy and Drug Shop, or Drug Shop and Pharmacy Technical Working Group, that was organized in part through the IBP network. And what we realized, of course, is that it has a lot of overlap in terms of focus. And so we've invited that group to join us, and we will make special effort to highlight Pharmacy and Drug Shop activities and topics. So we'll tell you a little bit more about that at the end of the session. But just want to say a welcome to those folks as well, and a big thanks to Sophie Parwan, our technical lead from FHM Engage, who really organized all of this. And then always to Farhan, who serves as our moderator from Tanzania. So Farhan, over to you.
Okay, thank you so much, Andrea. So a few, reminders for our participants, that this session is going to be recorded because we love sharing all these learnings with other people who may not be able to join us today. Please reminding everyone to mute themselves until we reach either if you are presenting or we go to the discussion section where we will allow everyone to speak. Of course, everyone is welcome to keep communicating on the chat as the presentations are ongoing. Please feel free to share your thoughts, ideas, your questions, and the speakers and the presenters will either get to them while we are presenting, or we will discuss them during the discussion at the end of the sessions. As mentioned, we are, focusing on Liberia today, a lot of exciting things happening there. And so to start us off today, as again has been customary for these sessions, we have a presentation on the market description, what is currently happening in the FP market in Liberia. And to do that, we have our presenters, Luke and Kristen. Luke and Kristen, please take over. A kind reminder to all presenters, we have 8 minutes to present, and I am known for my strictness as far as time goes. So yeah, please let's try and maintain time so that everyone can present and we can have fruitful discussions at the end. Welcome, Luke and Kristen.
Thank you so much, Farhan. Can everyone see my screen? Wonderful. All right, thank you. We'd like to take a little time now to discuss some of the family planning market intelligence work that the FHM Engage project is leading in Liberia. My name is Kristen Devlin, and I'm a senior program manager with Genesis Technologies. I'm joined by my colleague, Luke Krangar, who is a project advisor with Genesis, focusing on health information system strengthening on FHM Engage. So in our presentation today, we'll define what we mean by market intelligence and then describe 2 of our market intelligence activities to date in Liberia, which will serve as a brief scene setter for the session describing the family planning market in Liberia. We'll then conclude with just a few steps about where this work might go. So what is market intelligence? In order to define market intelligence, we at Genesis feel it's important to describe how the concept builds upon the concepts of market data and market information. In that regard, we'd like to present one way to think about the process of translating market data into market intelligence through efforts to structure, harmonize, and analyze this data. So first, what do we mean by market data? Simply put, we see this as a collection of facts related to supply and demand of healthcare products, services, and information. Market data can be qualitative or quantitative, structured or unstructured, fragmented or harmonized. Examples could include data related to family planning product price, volume, sales, and market share. Market information, on the other hand, refers to data that have been processed, organized, and structured. Therefore, market information is in a more usable form for analysis. Market insights then refer to data that is analyzed and synthesized to generate a deeper understanding of market dynamics. And then finally, we come to market intelligence, which we see as the interpretation of market insights to inform actions, recommendations, or decisions about the market. This diagram here represents a health market system with supply and demand in the center and supporting market functions and rules and regulations surrounding them. We see that market information or market intelligence is a key supporting function for a healthy market. This slide shows FHM Engage's market development approach, beginning with the diagnosis stage, where market challenges are identified, through the design stage, where solutions are co-created and planned based on evidence, through the deliver stage, which entails implementing solutions, and then finally the step where adaptations or changes are made based on monitoring and assessment data. Market intelligence is crucial at each of these stages of market development because data and its interpretation are so integral to planning, designing, assessing, and iterating our effort. Here are some of the common challenges to being able to produce and use market intelligence. Many of you here today might be very familiar with these challenges, but we wanted to highlight these examples in one place and emphasize the complexity of these challenges in the context of multiple actors in a market system, and really emphasize that they require a level of effort to overcome. We don't have time today to describe them all, but at a high level, they include data fragmentation, or when data is scattered across diverse systems, sources, sectors, and entities in different formats. The fact that data sharing and data governance across sectors is often non-existent or insufficient, thereby accentuating information silos. Concerns about data privacy and confidentiality, which are often very real and understandable. Responding to questions such as, how will my data be used, should be of high priority. Finally, these issues can exacerbate existing mistrust or limited collaboration across market actors. So we've drafted a framework that outlines approaches to strengthening market intelligence. Here on the left, we can see that some of the strategies that can be taken to address market intelligence challenges that I just mentioned, for instance, facilitating market data sharing partnerships and creating shared value for market data. Moving along the diagram, we've identified some of the outcomes that might result from these strategies that can contribute to a healthier market through a process that brings together local market actors. So now I'd like to pass it to Luke to summarize FHM Engage's family planning market intelligence work in Liberia to date.
Yes, thank you so much, Christine. So our market intelligence work in Liberia to date has focused on information gathering during the diagnosis stage of market development. And during this stage, we've engaged with key market actors, described the landscape, and have begun to propose recommendations and solutions for further discussion. Specifically, we have developed the family planning market description, and we've documented family planning data landscape. For each, we have synthesized findings and recommendations for stakeholders and strengthen the family planning market, Our focus has been particularly on market data and market intelligence. I will now describe these activities in a bit more depth. In regards to the family planning market description, the purpose was to provide a holistic view of Liberia's family planning market, including the trends, clients' profiles, and the role of the private sector. This information also serves as a shared baseline understanding of the family planning market situation, including challenges and opportunities to increase family planning access and use through the private sector. Through this approach, we are seeking to initiate dialogue to validate and inform the design of market interventions alongside partners in Liberia. Our approach included reviewing key documents, performing a secondary analysis of the Liberia DHS and other data, and holding key informants or consultations. We have many findings and takeaways that we look forward to sharing, validating, and exploring with MOH and the market actors. In the market description, we organize these findings by supply, demand, and supporting market functions. Here, we will share just a snippet of these findings, and I hope that they gave you the sense of general family planning or landscape in Liberia. First, importantly, just a quarter of women in Liberia use family planning, and 37% of those family planning users go to private sector for this method. In many ways, this unsurprising given or the rapidly growing private sector in the country. We estimate that there are more than 400 private facilities in the country, representing about half of the total number of facilities, in addition to at least 400 pharmacies and 1,000 medicine stores. However, the growth of the private sector has produced regulatory challenges, making it difficult to understand the scale and scope of this sector, including the number that are functional and fully operational in one given moment. This also makes it challenging. To ensure quality in provision of family planning and other products and services. The market description elaborates on some of the concerns that private providers have, including poor access to sustainable financing options, which jeopardizes their ability to provide quality products and services. In fact, a recent survey, more than 100 facilities showed that 95% are financed uses of service fees and or their own or personal funds. As it is true in many contexts, the family planning market is not meeting the needs of younger people, especially those between 15 and 29 years of age. The highest unmet need is among women ages 15 to 19. While there is considerable demand for family planning, more effectively reaching this group with youth-friendly services is a key priority. The private sector is already playing a key role here because private sector sourcing of FP, especially from pharmacists, is highest among younger women. So it would be important to continue to explore and identify ways to strengthen the private sector engagement in FP provision, especially for this group. On a positive note, private sector engagement and strengthening is a key priority or key pillar in the country's recent FP 2030 provision. Another takeaway from this exercise was that women from the lowest wealth quintile in both urban and rural areas have high unmet need for family planning. Interestingly, a sizable proportion of women in this group, as well as women from other wealth quintiles, source their family planning method from the private sector, despite free contraception being offered through the public sector. This suggests a willingness to pay for contraception. We have recommended that this concept be further explored. Finally, at the moment, there is no clear steward for family planning market. Instead, there are limited or piecemeal efforts to coordinate, collaborate, set agendas, and make data-driven decisions related to family planning. In that regard, we have suggested developing a stewardship platform and focusing on efforts on building shared value across family planning market actors. Secondly, the purpose of the data landscape assessment was to identify data challenges and
Sorry,
solutions.
Luke, in the interest of time, can you please just summarize? Thank you. Apologies for that, but just in the spirit of time, if you can quickly in a minute summarize some of these things. I think the findings were amazing. Thank you.
Thank you very much. All right. So there were some specific things we found. One of the questions was, what family planning data exists, in which system and sources, which ways, is family planning data fragmented, what specific family planning or issues are stakeholders sitting with that they are having difficulty addressing, especially related to this data fragmentation issue, and what solutions also might be appropriate to address these challenges. So our approach included reviewing key documents, data sources, and systems related to family planning, as well as holding key informant consultations. And our finding included family planning data exists across at least 6 different electronic or systems or sources, including the DHIS2, the ELMIS, the MSupply, community-based information system. And then within these systems also, NGOs having their own data, social market, commercial actors, all of that. And then the data we collected on different timelines and organized a range of formats across these systems. And, an example of this or fragmented data is how 3 standalone systems, the DHIS2 and ELMIS, MSupply, all collect and store from the planning or supply chain data, but these systems are able to communicate with one another. So our recommendation towards that is that we should directly think about, or just in line with the ministry's vision, think about data integration and data interoperability, which are solutions actually that the ministry itself has proposed in dealing with some of these challenges. Finally, we just wanted to share, a few steps we hope to take in the next weeks regarding market intelligence activity moving from diagnosis stage to design and delivery. So the first thing we want to do is to seek more
Luke,
Yes.
I think we'll have to stop here. Maybe we can find some time later on to talk about the next steps, but I think the findings are quite interesting and enough to generate some conversation. We can talk about some of these things perhaps later. Thank you so much, Luke. I think, market intelligence is something that is always of interest to this group, and it always keeps coming up as a topic. I think, in the interest of time, let's move on to our second presenter, that is Veke Donzo from Chai. Veke, are you here?
Yes, I'm here. I'm trying to share my screen now.
Welcome. I think we already have your slides, so they will be shared.
Okay, if they're not shared already, I've just shared them.
Oh, okay, great. Then go ahead. Ahead.
Okay, so hello everyone. I'm Veke Donzo from Liberia. So I'll be presenting to you on a study that we did along with the ministry I have in Liberia. And the study was titled Acceptability and Feasibility of DMPA-SC self-injection in Liberia. And to just give a little background, DMPA-SC being injectable contraceptive with lower dose formulation as compared to depot that is being used in Liberia for a longer time. And because DMPA-SC is something that can be injected under the skin, and it goes for the same 3 months as compared to depot. And DMPA-SC being an injectable that was recommended for self-administration by WHO, the Ministry of Health, along with partners in Liberia, decided to introduce this product in 2018. So the introduction was done in one of the counties, Riverside, through the community health existing program. And after that, there was a need to scale up that pilot. So the ministry developed a scale-up guideline to go ahead. But one of the issues that came up during the discussions was that there was no Liberia-specific study or evidence to inform as to whether DMPA-SC self-injection was something that was acceptable or feasible in the Liberian market. So based on that, a study was recommended, and this study that I'm going to be presenting to you came out of that arrangement. And the study went for like 6 months. That was the first half of 2022. So during the study, the 187 clients was captured in the HMIS or ledgers during the study period. And of those 81 consented to participate in the studies. Consented meaning that they were willing to talk to the data collector as to their experience, whether it was acceptable for them to continue with the self-injection. And 95% of those that participated in the studies self-injected at the facilities, and they went home. 36 of those are continuing the self-injection at home. 95% completed it at home as well. So, and when we asked them as to the reason for why they chose to do self-injection, most of them said because it was a convenient option for them. So some of the reasons that they gave specifically was because it reduced their transportation to the facility. So it was easy to be home and just do self-injection. And because of that, also it saved them time and money. It also helped with their own autonomy of administering the product without asking for allowing the husband to know about what they were doing. And then another question that was asked during the study was as to whether it was easy for women to self-inject. And you will see women say it was easy for them. Up to those that self-injected first time, 34% of them said yes, it was easy. And most of them actually said it was somewhat easy. Very few, up to 6% said it was very difficult for them to do. So this implied that most of the women that self-injected found the self-injection easy to do. And one of the concerns that came up when this study was being designed was whether it was the storage at home for the commodities. And so some of the questions that we asked during this study was to know how women were storing the product at home. And most of them said they were putting it in their handbags and suitcases in order to keep it away from their kids or adding it from their partners if they were not in agreement with using contraceptive. So you will see in the graph that we'll be sharing later with the team that these are the different findings that we found in terms of storage at home. And stakeholders also was concerned if you introduce a commodity that women are using in the communities to do self-injection, how are they going to dispose of the waste? And you will see that women actually said they were putting it in a plastic bag and bringing it back to the facilities as recommended by their trainers. And some of them, 31% said they were putting it in the pit latrines. So the finding shows that women were able to dispose of the products, the waste products at home. And in terms of overall client satisfaction, women that did the self-injection said they were very confident 69% of them said they were very confident to do the self-injection because they were being trained by the facility staff as to how they should do it. So up to 91% of those clients said it was very likely that they were going to continue with the self-injection. because they find it satisfactory. And I will also look at the provider perception of self-injection. Providers, we ask them as to what they were thinking of giving women the commodity to go home and do self-injection. And they overwhelmingly believe that there was an option that was worth looking at because it saves time for them. In most of the facilities that we work in, you see there are long queue going to a provider. So usually providers are overwhelmed with the caseload. So self-injection was a means for them to be able to provide contraceptive to women without going through the headache of the day. So in conclusion, we submitted that self-injection was an acceptable and feasible family planning method for Liberia. Findings suggest that providers can effectively counsel and train people on DMP, SC, SR, and clients are able to self-inject at home and also dispose of the waste, because these were some of the concerns when this self-injection was being introduced. And nationwide, a self-injection scale-up will increase the access to family planning method and also the individual privacy and autonomy, and also increase women's right to SR services. And then we also concluded that other SR, HR, or self-care interventions should be considered to improve the population health outcomes, since it increases privacy and also autonomy of women. Thank you.
Thank you so much, Veke. We'll keep the questions for the end, but I think, again, a very interesting presentation because, self-care interventions and the private sector really go hand in hand. And a lot of these concerns that you have mentioned are exactly concerns that many other African countries have when it comes to self-care, and especially through the private sector. So thank you for sharing those findings. Moving on, we will now have a presentation from Regina Hodges of the Planned Parenthood Association of Liberia. Welcome, Regina.
Thank you very much. We will be looking at demand creation. Over the years, we at the Planned Parenthood Association of Liberia have been complementing government effort to reach sexual reproductive health and right goals. So we have been looking at demand creation for family planning for young people. And we have implemented some of the activities, some demand creation activities that we are going to go through. But before going into our presentation, we would like to give you a little background of the Planned Parenthood Association of Liberia. The Planned Parenthood Association of Liberia is formerly the Family Planning Association of Liberia is a non-for-profit, volunteer-based, non-governmental, and non-political organization that is complementing the effort of government of Liberia in the area of sexual reproductive health and rights in Liberia since its establishment in 1956. In 1972, based on a presidential proclamation, the association was incorporated into Liberia's health program and enacted into law by the government of Liberia in 1976. So here are some demand creation activities that we have established and implemented. So we have been able to establish the Youth Action Movement in 6 counties with a total membership of 180 young people. So the Youth Action Movement is a auxiliary group of the Planned Parenthood Association of Liberia that is fully membership of adolescents. And this group is geared towards to promote adolescent sexual reproductive health information among young people. So this group is about mentorship to peers to peer mentorship. We have also been able to organize special community outreach sessions in 30 communities, reaching 3,500 young people with SRH information services. And then we have been able to assist the establishment of 9 health clubs in schools. In 9 schools, we have been able to work with young people in various high schools to establish health clubs on sexual reproductive health and rights. We have conducted adolescent sexual reproductive health or family planning dialogue with 100 parents and teachers from different communities, including Bartnersville, Banke, Totokwale, and Carricksburg. These are rural areas in Liberia. So the reason for having this dialogue with parents and teachers is to also get the parents involved in having adolescents being informed about family planning services and how to make proper use of them. And then we have been able to conduct adolescent sexual reproductive health or family planning dialogue with 50 faith-based organizations in Monrovia or Montserrado and Bapolu counties. So there are some faith-based organizations that still don't want to hear about family planning. So we have been able to talk to them, to have dialogue with them and explain to them the need for family planning in these counties. So here are some of the challenges that we have been faced with over the years. Number one is sustainability of the adolescent sexual reproductive health and rights services and the solid business model. Number two, youth refusal to easily accept adolescent sexual reproductive health or family planning information. So sometimes you go to talk to young people and they will tell you that they are too young to take family planning, or if they are not have children, they cannot take family planning. So in fact, some of them will tell you that they want to start having children first before making use of family planning services. And then number three, we have difficulties in integrating adolescent sexual reproductive health services into the public health facilities. Sometimes we go to talk to people in the public health facilities, they will tell us that they do not have spaces there to give to us. So we have had challenges in trying to integrate these services, some of these services. And then demand creation is cost intensive. So we have had challenges with finance. The last, but not the least, limited involvement of the traditional and religious leaders in support of sexual reproductive health and rights services or activities. So here are some of the lessons that we have learned that we would like to implement when we are looking at another activities. So the involvement of traditional and religious leaders in sexual reproductive health dialogue help to provide support for young people at community levels. Social media for outreach to create youth on to educate the youth on sexual reproductive health issues. So social media, we have learned that social media is a powerful tool that we can use to get to young people with sexual reproductive health information. Training of media personnel on SRH provided opportunities for SRH messages to be disseminated correctly through different media platforms. So if we are able to train young media personnel, we think that our messages can be able to go across correctly. Special community outreach sessions to the community levels provided opportunities to reach more young people at the community level than the clinics. The last, integration of adolescent and youth services into the public health facilities helps youth to access SRH information and services easily. Yeah. Thank you very much.
Thank you so much, Regina, for keeping up excellently with time and yet giving some very interesting insights. I know across the different countries that we have featured in this community of practice, we always notice this question of youth coming up, and much of the data is showing us that that is the group that we are missing. So it's always interesting to see all these different insights that are coming from different countries related to what can be done as far as youth and family planning is concerned. So thank you so much for that. Moving on, we have a presentation from Jemseta Smith from Breakthrough Action.
Hi, everyone. Am I audible enough?
Yes, Jemseta, we can hear you.
Thank you. So I will be sharing with you Breakthrough Action contribution for demand creation for family planning uptake among young people and adolescents. So Breakthrough Action is a global flagship SBC project, and in Liberia, we support an integrated SBC intervention led by Johns Hopkins CCP. We implement across 12 counties supported by USAID, and for our FP intervention, we seek to support the increased use of FP among sexually active adolescents and youth, as evidenced by the data from the Liberia Demographic Health Survey, which points out to a high teenage pregnancy rate at almost 50%. We also conducted a baseline study in 2021 that identified exposure to message, peer communication, and service provider communication, as well as the availability of commodity as a key determinant for family planning use. And also from the Demographic Health Survey, we identified that family planning use among sexually active women is still at 45%. Next slide. So for our adolescent health approach, we use a behavioral economic approach to understand young people behavior and their choices for family planning and reproductive health issue. And this module is quite similar to that of the market economy-based approach, where we work with young people across 8 counties and try to understand what their needs are in terms of making decisions, what their perception are, and their level of exposure. And we had a co-design workshop with these youth, and working with them, they were able to come up with 3 activities that focus on family planning campaign, the use of social media, and adolescent health club activities. So for the purpose of this presentation, I will be speaking mostly on the adolescent health club approach. In the recent being, along the way, as we work with them, we use their feedback to improve our intervention. So what interests them most was the issue of the adolescent health club, because within this club, they could have that interaction with their peer. So as we receive feedback, we modify the versions of our club's activities. So we were able to design the adolescent health club card, and within the adolescent health club card, we incorporated lessons on the effect of early sex, teenage pregnancy, amongst other reproductive health topics. And based on their feedback, we had to have 2 separate disaggregation of sex from the club. So we have boys club separate from girls club. And then within each of the club, we have supervisor who supervise the teachings of the club lessons. So a boy club was supervised by a male from the community identified by the county health team, and a female club was supervised by a female. So along the way, we use feedback from the market to make improvement to our intervention. And based on that, we are now rolling out adolescent health club information to existing schools within Liberia. Next. So this is the last slide, and just to share our results and lessons. So within 2 years, we were able to establish pretty close to 500 adolescent health clubs in various communities across our 12 project counties. Liberia have 15 counties, so we are currently working in 12 counties. And the lesson incorporated into the adolescent health club, we have 16 topics. And each week, we ensure that the supervisor are able to teach one of the topics. So the entire cycle runs for a period of 16 weeks. After that, we assess their level of retention, and then we are able to provide them certificate that they have completed all of the topic to make their informed choices regarding their family planning needs and their reproductive choices. So along the way, we were able to modify our activity, like I mentioned in the previous slide, based on the market needs, what interests them most. And we also realized that community participation in ownership is a major driver for the uptake of family planning services in decision making. And another lesson is that the intervention is very cost effective because we have to provide incentive to the supervisors that were teaching this lesson, the minimum of $50 to supervisors to supervise the lessons. We also recorded high retention as a result of supervisors who have a better understanding, who could better present the information to the youth. So for the ages in the club, it ranged from 13 to 19 years old. Okay, so there's a question in the comment I already addressed. So though we learned lessons, there were also challenges. And just to mention a few, we realized that the supervisor capacity was very key because it had a bearing on whether the youth have more interest in the discussion, and it also led to low retention if a supervisor capacity were not on par. So we identified that supervisor capacity across all of the county were not the same. There were some supervisors that had better understanding, they had better approach to presenting the club lessons to the youth. There were also an issue with migration of youth, especially during the closure of schools. People have to move around to other communities and other counties. That also impacted some of the youth completing the cycles of lesson. So to address this, as I said, we continue to receive feedback. So based on these challenges, we have now incorporated the Adolescent Health Club lessons into existing school health club guide, working with Ministry of Education and Ministry of Health. So for come September, we will be rolling out to additional youth within the existing school health club. And our target is to work with 10 schools per county. So the total is 120 schools that we are targeting to roll out and provide the rightful information on FP and RH so that they can make their informed choices. Because we know in Liberia, most youth, once they engage in commercial activity, it's most likely that they will indulge into sexual behavior that are risky. So it's better that we give them the right information to make informed choices. Thank you.
Thank you so much, Jemseta. Again, another interesting presentation on youth engagement. And I think particularly to see that you are able to work with the different ministries to incorporate some of these things, because again, we see that in some countries that might be a challenge. So definitely a very interesting learning, and hope to be able to discuss a bit more on that as we move on. Next up, we have Sarah Hodge from Last Mile Health.
It's okay. It's there. Okay. That's what I needed. Okay. Good afternoon to everyone. So we'll be talking about family planning commodities and distribution in public markets. Next slide, please. That's country. Okay, so we have access to family planning commodities in public spaces, especially the public markets. This is a project that was done in past years, and we just want to share a short story about what we did. The case of building, it was about the case of building strong partnership with the Liberian Marketing Association for the distribution of family planning commodities. So for the background, we have in Liberia, Liberia had the highest maternal mortality at that time, which was 994 over 1,000 live births, and also have the highest unemployment mortalities, which we did not measure here. For now, we know maternal mortality has reduced to some extent, but at that time, this is what we have. And USAID supported the family planning of People Health Project through GSI in 2010 at that time, or carrying on the project for RBHS. Under the MOH, we have the family planning ROH focus on health facility and awareness and outreach. So the family planning services at that time, the focus was only at the facility level, and from the facility level, the health provider go in the community and conduct outreach, and to that outreach, they also distribute some communities. But then at the facility level, we also have the midwives and nurses that also provided the services to women and men while they were creating to create demand and health. And the health worker facility, the health worker will also visit the surrounding community to promote the use of and uptake of family planning for the reproductive health services, or part of the reproductive health services. So the market distribution was introduced to give access to adolescents to the informal structures in the public markets. So at that time, the reason of initiating this intervention was to increase demand. Demand was already being created through outreaches and through other means. And then at the facility level, the health provider, the midwives, and the nurses will provide the communities. But then we studied why the other group that were left out. So we decided to introduce the market projects at the market ground, selecting and targeting various markets in two counties. So we have the urban and the public markets that were selected at that time. It was done in two counties. It was in Monserrate and Grand Bassa. So we have few markets that were selected in these two counties. We selected markets ground that were densely populated with women, and then and the communities. We knew the community that were densely populated with women and even young girls, young people. So the Marketing Association granted us the approval and provided us space for us at that time to to store the communities and carry on the services. So what will happen is weekly, we also in these market grounds, they have weekly market days, in the urban area, and in a rural area, they have market days. So during the market days, people go, health provider go, and they create demands by carrying on, awareness on family planning communities that are available in the facility. So with this initiative that we started with the market grounds, going into the market grounds, talking to women and young girls, young boys, telling them about the availability of the communities that were in the market grounds, or that were placed in the selected market spaces. So we did that to the county health team, and data and monitoring aspect were done to the county health team. We're not just giving the communities and then putting it at the market ground, but the county health team to the two counties that were part of the initiative, and the community were stored. We had a place to store it. At the end of the day, whatever that was given out, it was documented, and the data was monitored and placed and given to whatever in place where they have to carry it for monitoring purpose. So the marketeers, they opted for pills. We have two communities that were mainly giving at the market spaces. We have pills, the oral pills, and we have condoms. So those two communities mainly were given in the marketplaces. But the marketeers, they opted for mainly the two communities, the pills and the condom. And for other options, for other methods, referral was done to facility like the injectable and other methods. Referral was done to the facility level, so that whoever that wanted the injectable, you have to go to the facility to get your injectable. So this one, it was also an opportunity for the young people, especially the young people that were in school, because most of the time after school, most of the facilities have already been closed, so they don't have access to family planning communities. So when we have the market spaces where communities were still, the initiative was provided for them. They had the option to go after school. They will go in the market. Maybe they went to buy food. They will have their services before going home. It also, there was one of the achievements that we had. So for achievement, we had increased uptake in family planning communities. What happened? That is, family planning community uptake went high. Because at first it was only at the facility level. So if you missed out for the facility level, maybe because you were in school, that's it. But when we took it to the market ground, it increased the uptake for family planning communities. And another thing that one of the gains were the marketers retain the FP clients as our business customers. They had the business customer, they had, they were with them, talking with them, they encouraged them to carry on, to access the communities. And another thing that was done, if confidentiality was secure, even though it was at a public place, but the marketers provided of space with, that were closed up with door and everything. So confidentiality was secure, particularly for the adolescents who felt that maybe if they were identified, if they could see them in those places, they would be mocked at. So confidentiality it was secure for the adolescents who could not be able to identify because they were viewed as ordinary buyers. They look at them as ordinary buyers. They go in the market to buy their food, and they just slip into that little space and get their services, and then they go home. We had the FP market distribution that continued in 2 of the 5 marketplaces. So after that, we also have, up to now, we still have the 2 places where distribution continues. Even after, because of donor funding, things started breaking down, but we still have the two places where distribution, Grand Bassa, I think, and even in Mosurado, distribution continues, or is still going. And we had a referral of clients to health facility for other mentors. That is still ongoing. So these are some of our achievements that we made, the gains that we made. For challenges, we had limited choice of mentors. We had the users and provider bias against storage facility. Of course, one of the challenges that we had, and donor driven. After the donor, funding went out, some of the facilities began to close, and that led us to have only 2 marketplaces providing services today. For lesson learned, the public market family planning distribution dispel the myths that
Sarah, if you can please summarize the lessons learned, because you're almost out of time. If you can please just quickly summarize.
Okay.
Thank you.
Okay, so as you just look at that the last slide, these are the lessons learned that we have. We have offer range of benefits for adolescents and the business interests of the sellers. So thank you.
Thank you so much, Sarah. I think a great example of finding the youth where they are rather than waiting for them to come to us, and also using a sort of private sector environment to be able to do this. So thank you so much for that, a very interesting example. We'll now move on to Isaac from DKT.
Yes. Okay, thank you very much, everyone, for the opportunity. Good afternoon. My name is Isaac Lamte. I'm country manager for DKT Liberia. I also have my colleague Amanda, who is our program manager, on the call. So just briefly, DKT is 5 years in Liberia. Not so long in Liberia, but we're celebrating a little modest efforts here. So thank you. I'm sure that DKT is the typical private sector operator leveraging on the social marketing model to make contraceptives available. Our work, maybe next slide quickly, we will go through. Our work has typically focused on 3 main areas. First, in terms of expanding access to contraceptive commodities, and also generating demand and creating awareness. Because I think that the market survey that FHM read in the beginning of this meeting gave a lot of background and a scope within which that DKT works fit in. So there was the need for that one. So generating the awareness for these products, because people know it is there, but how do they know and how do they access it? And also for some of the commodities that we deal in, we will require specific skill to be able to provide them. So there is the need to work with the Ministry of Health, particularly to build capacities to ensure that quality service are delivered at the end to the final client. Next, please. So we are very fortunate to have the full portfolio of family planning commodities or contraceptives in Liberia, from the condoms to the pills, the emergency pills, the regular pills, the injectables. My colleague from Chai talked about DMPA SC. We were involved in the introduction and distributed. But in addition to that, we have also introduced the IM, given the challenges that we had in assessing DMPA SC with the manufacturer. We also have the medication abortion pills, which are in circumstances where they're permitted by the law of Liberia, the implants and all of the portfolio. And we also have launched the self-testing kits for HIV/AIDS also in Liberia. Next, please. We just ensure that we are not concentrated in Monrovia, because also definitely we are challenged by the difficulty in connecting the different counties, 15. So we have managed to set up satellite distribution points in all the regions or the counties so that we are able to be present. I will share highlights on how this becomes beneficial, because in the next slide, please, because in Liberia, for family planning contraceptives, it is typically by way of direct distribution. There are no effective intermediaries like distributors or wholesalers who will take it, largely because the market is too small, profitability is almost not present, and sustainability is difficult. Next, please. So you will find that in a typical setting, these are some of the areas that we need to connect, either to connect to the southeast or to the River Cess or to, say, Bomi County. And necessarily so, we need to do this directly from our sale agents, we showed, and also to our medical detailers. And we have categorized our distribution agents into 2. The regular sales that goes through pharmacies and medicine stores, and the medicalized products that goes through clinics. Next, please. Yes, so fortunately, we are able to support our logistics with also some branded and visibility materials that gives also a contribution to what we want to do. So Lydia is the female contraceptive range, and in terms of case condoms, we have 2 bigger variants in Liberia. The Fiesta condoms coming in 6 different variants, and Kiss condoms in 2 variants. And where it's very difficult to access with vehicles, we are also supported with mobile, the motorbikes. Next, please. Okay, so a lot of work is done about how we generate awareness, particularly engaging young people. And we find also that in Liberia, a lot of the young people look up to some established, what they would call celebrities or influencers. So we try to build a network with these, some of these people, and they use their network in social media and also on ground in schools and communities to gain attention to them. Next, please. In addition to that, we also use a full deployment of mass media. So you find us engaged in a lot of radio, a lot of TV campaigns, billboards, also in a way to create awareness. We have fought every opportunity to brand. You find some buses that fly from Monrovia to Nimba to Grambassa, all of that. Anywhere we can catch attention of people to get aware of the use of contraceptives, we have used it also. Not only in mass media, next please, we also have the opportunity of utilizing on-ground mobilization. Even the street vendor is also a very good opportunity to brand something and to gain awareness in there and in the facilities in which we work as well. Next, please. Okay, these are some creatives that we use also in generating awareness in different touch points, in posters, in flyers, and also by point of sale material. So we find out for the HIV self-testing kits and also the different ways. Social media campaigns, we are very dominant in social media for all three brands we have, and also DKT in general. Next, please. Okay, so we also have a very typical approach of reaching out to rural communities and people in low income ends, whereby we utilize our on-ground community mobilizers, most of whom are nurses, qualified nurses. We train and they utilize an interpersonal approach to reach people at the point where they gather and sometimes in their homes to be able to offer the education and the services as well. Next, please. Now we'll be talking more the capacity building because Luke, in the first presentation, talks about, fortunately, the availability of private facilities in Liberia. I think that's a huge opportunity that we have. He talked about 410, and I guess there are a lot more because DKT, we're doing business with close to 400 of these private facilities. But we have also created a separate kind of network that we are able to also support separately brand that we call the Lydia Partner Clinics. So if you go into a typical Lydia Partner Clinics, you will find a DKT branding. We have supported them, some counseling desks, sampling tables, some materials, some ways of demarcating the areas that is also visible for clients that go there to see. It's something we are not able to do for all 400, but we keep growing the network as and when we have resources available. Next, please. Yes, we are also deeply involved in capacity building. Capacity building is not only for midwives who offer long-term family planning services, but also you find the team in blue are pharmacy dispensers. These are people in pharmacies and medicine stores. We try to train them also on the correct use of the pills, for example, particularly the emergency contraceptive. What are the right ways to use it? When is it efficacious to use? Any possible side effects people to get. Then we train them and make available our in-house contact center that people can be referred to and call whenever they have such issues. Next, please. Okay, so we do not do this on our own necessarily. We have built a very wide network of collaborations, both intergovernment, international NGOs, local NGOs. We are very particular about our partnership with IEFO, which also enables us to focus on persons with disabilities and enhancing their access to contraceptives education. Currently, there's an ongoing training for a lot of persons with disabilities in the Bon County that we're training them on how to easily access contraceptive products in the various pharmacies, and also several rural community organizations that have easier access to final consumers. We sometimes give them commodities they are able to share. Next, please. I believe the last slide. Yes, so we are very modest in our results. We measure our results by way of a couple of years protection, CYPs. So between 2018 to now, we're very confident of generating about 882,500 CYPs. The overall effect of this impact is what is usually being communicated by the Ministry of Health, because we believe that all of the partners here and a few that are not here, they are all contributing. So we are not able to attribute and say we contribute this, because usually this will contribute to reduction in maternal mortality, pregnancies, maternal death averted, and all of that. But we are just able to communicate our CYP impact, and we believe that at the right time, the Ministry of Health communicates the overall impacts of these interventions together with other partners, and we are always credited for the impacts we're making, particularly with the private sector. But for clinicians trained so far, we trained over 3,000 clinicians in all 15 counties of Liberia. And like I mentioned, we also trained over 5,000 product dispensers, not limiting to pharmacists, but also dispensers, shop attendants, the tiniest person that is put there to have that skill to administer a condom or a pill, we give them also this training at the same level and with the resources that are deployed. So I believe this is my final slide. Thank you so much.
Thank you so much, Isaac, for that, very interesting presentation, a lot of use of graphics, great. And I think my sort of takeaway from this presentation is how friendly the government in Liberia is. I mean, the amount of branding and marketing that you are allowed to do, I don't think happens in some of the other African countries. So it's definitely a great opportunity, and I think you are utilizing it quite well. To the last presentation for today, maybe Livingstone from UNFPA, welcome. Maybe are you here?
Hello, can you hear me?
Yes, we can hear you. Please go ahead.
Okay, thank you so much. Next slide, please. Let me hang on. Okay, so we are excited to be part of this meeting to share with you the lessons we've learned implementing what we call the 3 access point model as a best practice for increasing young people access to SRHR services. Next slide. This is the outline. We're going to look at a little background, the partnership, the model itself, and the success facilitating factors and scale-up plan. Next slide. If you are in Liberia, the southeastern counties are very difficult terrain. We have this partnership with the government of Liberia and the Swedish government to increase young people access to sexual and reproductive health services. As you know, UNFPA within the UN system is the lead agency for sexual and reproductive health and reproductive rights. We are, in addition to USAID, we supply or bring in family planning commodities for the public sector. So with the situation before our intervention, the terrain is very difficult. At the time before our intervention, the only midwifery school in the southeast that supplied that entire region with skilled birth attendants were closed. The CHA program was not in place. There was the issue of frequent stock out. And because of the difficult terrain, we didn't have many partners with interest to operate in that region. So ultimately, we had the issue of the use of family planning method was low. There was high incidence of teenage pregnancy. Demand satisfied for family planning was also low. Delivery in health facility was around 57%. Next slide, please. So in order to intervene, we had a multi-sectoral partnership. We did not only partner with government, we also partner with youth-led organizations and networks, including the Federation of Liberian Youth. We also had the Inter-Religious Council, the National Council of Chiefs and Elders of Liberia are the traditional leaders, and also some NGOs. Next slide. So the 3 as this is the model itself, we have the first entry point is the community. We work along with women-led organizations and CBOs to carry out what we call the out of school comprehensive sexuality education manual. We train them. They have club to disseminate information and also motivate adolescents that are out of school. You know, out of school rate in Liberia is also high to access services. We also have the community health assistance program wherein we train people in community-based distribution of family planning commodity. The second entry point is the school, or the access point is the school. We integrated comprehensive sexuality education in the curriculum, the national curriculum for delivery in school. We also have the National School Health Program. These are national level system strengthening intervention. We developed a school health policy, and within the school health policy, we have school health rooms where the school health club will operate. And in these clubs, we made sure that we provided materials and train mentors and coaches, as well as train 5 adolescents in each of the school to manage the school health club activities. At the health facility, we integrated adolescent and youth-friendly services in corners, specific or specialized corners that were equipped to cater to the needs of adolescents, because the health facility is the central referral point for this model to work. We have to make sure to design innovative approaches apart from training service provider, the issue of stock, making sure that we have stock in these places so that when the young people come, they will have the services they need. They will have multi options to choose from. Next slide, please. So the impact, if you look at the counties we operated in, the counties with very high, MCPR, the contraceptive prevalence rate in these counties increased. As you can see from the map, previously this was not the case. Next slide, please. Also, other RMNCAH indicators also saw improvements after our intervention. You can see the difference between the blue lines or and the orange, so to speak. For example, prenatal checkup was low at 64. We increased to 78. Delivery in health facility was in these counties on the average was 57. 2020, according to the DHS, it increased to 83. Next slide, please. The impact on teen pregnancy, we can look at the bar charts. For example, we can see in River G had a teen pregnancy of 48. 2020, it dropped to 28. In Grand Juda was 57.9, it dropped to 27, and so on. Next slide, please. The percentage demand certified for family planning, you can see the charts there. They speak for themselves. They are clear. For Grand Juda, for example, we had like 38.4, but after our intervention, it increased to almost 63%. Unmet need for family planning also dropped as a result of the intervention, using young people as entry point to increase access to family planning services. Next slide, please. Also, the use of methods, if you look at the difference, they also speak for themselves. The use of family planning method was also low. If you just look at, for example, River G, it was at 30%, we increased to 40.6. I'm sorry for the noise. People are out in the corridor, the background noise, sorry. Also, deliveries within health facility also increased. Next slide, please. So what are the facilitating factors? The enabling policy environment. We integrated this model in the RMNCAH investment case. If you review the investment case, the issue of adolescent-friendly services approach is integrated there. The multi-sectoral partnership, including traditional leaders, the adolescents themselves was quite instrumental. We also partner with NGOs that were already based in the Southeast that had good rapport with the county health teams. The reopening of the school, this program also helped the midwifery school to reopen to make sure that we have skilled birth attendants. The capacity of the service providers within those facilities in adolescent-friendly service provision. The creation of specialized space where young people can just walk in at any time to access services was also good. We also learned that taking services to them in their respective communities through community outreaches was quite instrumental. In fact, most of our uptake came from community outreaches. pre-positioning commodities in this region. This is a very difficult region. During the rainy season, it's completely cut off. So in order to ensure sustained supply, we have to design innovative approaches to make sure that the young people have access to services. In addition, when you generate demand, you have to blend it with supply to balance the demand and supply side. Next slide, please. So
thank you. Maybe if you can just summarize the remaining slides. I'm not sure if this is the last one, but please, if you can summarize. Thank you.
Yes, so this is the last slide. The skill up plan, we scale up to Sino and River Access. We also align this strategy in our leadership plan. Thank you.
Thank you so much for maybe. And can I ask Dr. Jennifer to please mute?
She don't ask me. I just want to ask you. Yes. She don't ask me.
Okay, sorry, I had to mute everyone. So now, before we go into the discussion, we usually have a practice of asking, in case there's anyone in the participants who was not able to submit a formal presentation but wants to talk about their work that they are doing in Liberia very quickly. Is there anyone in the participants who would like to talk about something that was not presented? Okay, I see that there's no one of that nature. Now, moving on to some of the discussion questions, I wonder if the facilitators or the presenters have been seeing some of these questions that were very direct for some of the speakers. I'm going through the chat right now, but also if anyone has a verbal question at this point of time, please feel free to unmute and ask it. Just let us know who the question is for.
Yeah, and thanks, Farhan. Can I just jump in just for a second while you're scanning through the questions? So on behalf of USAID Washington, I want to say a huge thanks to the presenters and for going through relatively rapidly, because this is exactly our goal, is to get a flavor of the incredible activities going on. I also want to say a thank you to a couple of our USAID Liberia colleagues who are on the phone, and appreciate them joining. Shelley Wright and Simi Niamfor from the team, the health office team there. And again, also just a shout out to the people from various countries who are joining. We've seen a lot of folks on from Nigeria and Sierra Leone and other countries today, and that's fantastic. So also just to mention that all these slides and the recording will be available. So of course, Elizabeth sends those out. And with that, Farhan, back to you for any questions that you want to queue up, or for folks who want to come off mute with a question.
I think while we are waiting, I see one question because some of them have been responded to. I see the question by Soumya. Soumya, do you want to just come off mute and ask your question?
Sure, Farhan. Thank you. Thank you to all the presenters. I think they did a wonderful job, a snapshot. I had a specific question for all the programs that had worked towards increasing access to youth and adolescents. In one of the, as we all know, and especially as one of the presenters said, there's usually some degree of pushback to developing programs for youth and giving them access to commodities, family planning commodities, and especially if there's stigma around unmarried youth having sexual relations and such. So the question I had for you was, what was the argument that you posed to get buy-in in creating these programs? In other countries, for example, they follow this harm reduction type of approach, which is really to say, listen, this practice is happening, this sort of behavior is happening. What can we do as a program to minimize the ill effects of such behavior? Now, is that the kind of approach that that you all took in Liberia to get buy-in for services for youth, or was there some other approach? What was the approach that you took? What are the learnings that we can learn from your specific ways? That was basically the question. Thank you.
Okay, I see. Thank you, Soumya, for that question. All the presenters who presented on youth-related activities. Dr. Jennifer, do you want to respond, or is that another question?
Thank you, Fan. Actually, that question was in the chat, so I already asked the question. I just wanted to point out it was about referrals and referral chains and how that was designed and how do they determine the exact place where you would refer young individuals to. I think that probably is a big question and a bit linked to the harm reduction question also. And a question that we often get asked in West Africa, because usually a lot of the government, they're really interested in exactly, are you providing the right services to young people? And again, the question around what's the role of the young people in selecting exactly where they will be referred to? Is it public? Is it private? Is it not for profit? So that's my question. And I think it cuts across those who are working with the young people. Over.
Okay, thank you for that, Dr. Jennifer. And I guess, yes, that was another question that is linked and was not answered. And Andrea also sort of built up on that. So for those of us who presented activities related to youth, Regina, Gemseta, any responses?
Okay, thank you. So, Breakthrough Action. So for Breakthrough Action Liberia, we work through existing health structure. So we work along with the county health teams. So all of the work that we did, we collaborated with them to select the club supervisors. So club supervisors that were selected are people that are already known in the community. So we had a list of criteria that we use to select these supervisors. So there were information sharing in the community that we had the clubs, and were able to state the intention of the club. And then parents had their buy-in before the kids were enrolled in the club. So it was not forced, but it was a dialogue where we provided information on the benefit of the club, and then the supervisors who were in the club, who were supervising the club, were all people from the community that youth could relate to. So for some of the clubs, yes, we had challenge with one particular club in Nima, where we did a follow-up visit, and feedback received is that some of the parents were taking their children from the club because they felt that we're exposing them to early sex. So to be able to mitigate that, we have to go back to work with the existing structure, the county health team, the district health team, and even the health facility staff that are linked to those communities. So that's how we're able to mitigate some of the challenges. For referral, we are not into service delivery. Like I mentioned, we run an SBC project. So what we did was to provide information and link the youth to where they can access services. Thank you.
All right, so thank you very much for the question. We at Family Planning Association of Liberia, we believe that everyone should have equal access to family planning services and information properly. So some of our approaches have been working along with community leaders and the parents and teachers of these young people. Because yes, it is true that some young people feel discriminated coming to have family planning services. They feel that they are too young, but they are being exposed to sex already. So why is it that they cannot come to the facility to get access to family planning services? So some of our approaches have been trying to create safe spaces for them. So Safe spaces is one of the most important aspects of dealing with adolescent sexual reproductive health and rights. So we have been able to work along with the parents and teachers, telling them that it is important that young people have access to SRH information and services. So, and also religious group, because there are some people who have different religious opinions about family planning services. We have been able to work with some of these groups to make sure that young people be given the opportunity to have access to SRH information and services.
Can I come in?
Thank you for that. Yes, is that maybe? Yes, maybe. Go ahead and then we'll go to Isaac.
Yes, so to respond to your question using the system strengthening or system-wide approach, we conducted a couple of advocacy meetings with especially establishing the enabling policy environment that led to the integration of adolescent and young people friendly services in the investment case as a priority. And to do that, we have to show evidence. So we had to write a couple of advocacy paper, issue paper with statistics, and presented to the policymakers to have buy-in. We also work with the legal counsel, for example, at the Ministry of Health. There's a legal counsel there to integrate in the public health bill a chapter on SRHR, especially young people, adolescent access to family planning. As per law, the unmarried adolescent needs consent before they can access family planning services. So we're able to work along with the legal counsel to put in there a clause that will allow sexually active adolescents to access family planning services. We also did a couple of lobbying and something we call VCAT, that's value clarification and attitude transformation sections with lawmakers to establish the enabling policy environments. Apart from that, colleagues mentioned the issue of working with the county authority. We work with the county health team. We work with the religious leaders because most of these schools are led by religious entities. So to get their buy-in to integrate comprehensive sexuality education in the curriculum was tough. It was a very long journey. As you know, some countries even succeeded in integrating CSE, but they had to go back and say, oh no, we no longer want CSE. So to find a win-win, we had to agree, the government and stakeholders agreed, rather than saying comprehensive sexuality education, they agreed for us to name it sexuality education, just to add on to what colleagues said. So it requires lot of lobbying and using the partnering with the adolescents themselves to explain their stories, share testimonies about what their lives have been is a key driver to bringing about change. Over.
Thank you so much. Maybe Isaac, I'll give you 30 seconds to quickly summarize. We are almost running out of time. Karibu, welcome.
Oh yes, I just think the point you made, just to emphasize the approach towards the youth, the earlier question. I think also we found in Liberia that a lot of the youth also have some personalities that they look up to. What we talked about, the influencers. They can be comedians, sports personalities, musicians, radio personalities that they have that crowd following. So we're using these people as faces and engaging them on social media. It's also working, and also trying to connect in these places that the women, those youth gather. So it's always nice to engage them on social media, and also greater to also meet them in person as they try to inspire them to also get inspired to focus on their careers and other things they have to do. That's just also been one of DKT's approaches. I just wanted to mention. Thank you.
Okay, thank you so much for that, Isaac. So I see there's quite a few questions on the chat, which unfortunately we may not be able to get to because of time. However, as we always say, the objective of this gathering is so that people get in touch with each other, their network. Please feel free to reach out to the speakers and keep that conversation going. You have seen all the presenters, and I guess if you missed out on someone's name, when we share the slides, you're going to see them. We will now, I think I'll give just a minute to Sophie, our FHM Engage team leader for Liberia, if she wants to say anything and, share her excitement about some of this work that's happening.
Great. Shout out to all of the presenters, the over 6 weeks of back and forth. As we can see today that you are really well prepared, took off your busy schedule. So FHM Engage Liberia is currently supporting a COVID-19 project in 6 counties. We are transitioning to the Ministry of Health. We have some projects with the private sector unit. The unit has been set up, furnished by us, and we're also working with DKT. Thank you. I'm quite proud to be one of your, and Healthcare Federation of Liberia. These are our 2 co-partners for now, and we are growing gradually. We have a team of 3 staff with the hope of increasing to additional 3 in October. And we're transitioning our ideas into the marketplace, and we hope to interface with all of you at some point. Thank you so much for all your support. Thanks to our USAID colleagues. As Andrea said, thank you for taking up your busy schedule to join us, and UNFPA also. Thank you. Bye from our end.
Okay, thank you so much for that, Sophie. I think quickly I'll talk a little bit about what we are planning to do for the next session, and then I think, Andrea, you can close us off. I don't see Ben online, so maybe you can give the closing remarks. But just to inform everyone that because for those who attended the last session, you realize that there were certain presentations from Madagascar that we could not finish. And so what we are going to do for the next session, which will be in the month of September, is that we will dedicate some time to Madagascar and allow for some of those presentations that were not finished to be finished. And then remaining time, as you might have seen some of the conversations on the chat, we want to provide some focus on the pharmacy and drug shops related learning. So please, if there are people who want to share any learning specifically with regards to pharmacy and drug shops, doesn't really matter what country it's from, please reach out to us, because we are giving it a certain emphasis for the next session. And yeah, keep reach out to us with any thoughts, feedback, questions. Always happy to hear. Andrea, over to you to close us off.
Okay, yeah, thank you. And Ben Light sends his apologies from UNFPA because he couldn't make it today, but obviously we had a fantastic presentation from Maybe, so thank you for that. And this partnership is amazing, and definitely the pharmacy and drug shop topic. Isaac, you whetted our appetite, also thinking about other countries, and we know that we won't always perfectly be able to stick on a country only focus. So sometimes we will flex, and let's consider the September session an opportunity for some of that flexing. So reach out to us, and thank you again to everyone. Have a great rest of your day.
Great. Thank you.
Thank you, everyone. Bye.
Bye.
Hello, meeting.